Welcome everyone to our webinar on teaching integrated behavioral health with the authors of Integrated Behavioral Health in Primary Care. Please feel free to share where you're joining from in the chat as everyone logs in and gets settled. My name is Andrea Bergoa. I am the Higher Ed Marketing Manager here at APA Publishing. I'm going to start today with a few housekeeping items while everyone is joining and getting settled. Number one, all attendees are muted to prevent accidental noises and distraction, but we have provided multiple modes of communication and interaction for today's session. Auto captioning is enabled and can be accessed via the closed caption button. Chat is open and available for all attendees to use and to communicate with your other attendees and share your own experiences and thoughts. I do want to note that if you have any questions for our panelists today, please use the Q&A functionality at the bottom of your screen. That is going to help us keep track of any questions that are asked instead of losing them in chat. As soon as it is available, we will be sharing a recording of this webinar via email that includes captions and a chat transcript. The recording will also be posted to the APA YouTube channel as soon as we can. We'll be sharing any other resources and slides from this presentation if they are available. And finally, as recognition for your attendance today, you will be receiving an attendance certificate and badge that you can download and share on social media. Please be patient with us on those as they are a manual process and can take us a week or two to get out. Now I'd like to welcome you again to our webinar on teaching integrated behavioral health, and I'd like to introduce our panelists. Dr. Jeffrey L. Goody is a professor in the Department of Family Medicine with a secondary appointment in the Department of Medical and Clinical Psychology. A board-certified clinical health psychologist and retired U.S. Public Health Service captain, Dr. Goody brings more than 2 decades of leadership advancing the integration of behavioral health into primary care systems. He has taught integrated primary care at the graduate, internship, and professional levels, both nationally and internationally, and has led training, research, and implementation efforts in the primary care behavioral health model to enhance readiness, access, and health outcomes across diverse populations. And Dr. Christopher Hunter is currently the co-director of CNC Hunter Consulting, with an interest in applying his experience and expertise to health systems and clinics that want to establish, expand, or improve their integrated behavioral health services in primary care with a focus on whole person and team-based care. Prior to his current position, he led the development, implementation, dissemination, and quality improvement efforts for primary care behavioral health services in the military health system over a 14-year period. I want to thank you both for being here, and I'm going to go ahead and turn it over to you.
Great. Well, thank you. It is a pleasure to be here with everyone. And today we're going to be talking about teaching integrated behavioral health in today's graduate and clinical settings, and really specifically focusing in on how you might use the book that both Chris and I are co-authors on, Integrated Behavioral Health and Primary Care, Step-by-Step Guidance for Assessment and Intervention, how we've used that for teaching, particularly at the graduate level, but also talking maybe a little bit within other kind of clinical settings. Just as we get started here, first and foremost, my job is within the Department of War, but nothing that we're saying here, none of these opinions are representative of where I work or the Department of War, the Defense Health Agency. These are all my own comments as well as Chris's. So we're going to start out, Chris is going to start out just giving an overview of sort of the integrated primary care landscape, talking a little bit about why this topic is valuable and important, not only within our healthcare system, but also why it's important to teach about that. He's going to be talking about some of the key topics and competencies that are related to integrated primary care education. And then I'll talk more specifically about sort of practical teaching strategies, how how I've gone about talking about it. But then really, we want to make sure that we leave time for questions at the end where we can kind of address questions that you might have that in case you're thinking about teaching in your own setting, and we can talk about ways that you might be able to adapt kind of what we've done to where you're at. And so with that, I'm going to turn it over to Chris and to talk about this overview of integrated primary care.
Yeah, thanks, Jeff. I appreciate that. And thank you all for taking time out of your busy schedules to join us. We hope that you'll be able to have some good takeaways that you can apply to the things that you're interested in doing currently. Just as some additional context, I've been working in integrated primary care settings for the last 25 years, not only as an integrated behavioral health provider. I'm a clinical health psychologist by training, but I have also worked in APA accredited internships and have taught and trained psychology interns to work in primary care. So, one of the things that we think about in terms of why in the world we ever want to integrate into primary care, right? We spend all this time training to be, doctoral level psychologists or master's level mental health people. Why would we ever want to do this? And I think part of the reason is that only a very small percentage of the folks that would benefit from seeing a mental health provider are going to ever get that care. And I think as we've seen, especially as the pandemic rolled out, access to qualified mental health providers in the specialty setting is less and less. It's even more difficult in rural areas. People don't necessarily want to make those steps to go to see this mental health person that's over here that I don't know. And so when we look at those who are actually getting good evidence-based informed care, compared to those who might benefit from it, we're really only hitting the tip of the iceberg. And most people that could benefit from good behavioral health services either don't have access to it, won't go to it, it gets delayed, or they don't even know it exists. So that's part of the reason to integrate into primary care. You put the resources where we know people are going to go. It's not uncommon for people to have a primary care or a go-to physician. In the perfect world, they get to know that team, they stay there. And those teams, when they're operating at their best, it's not just a primary care provider and it's a nurse, but it's also other people that round out that team. So not only an integrated behavioral health provider, but in my perfect world, do we have a physical therapist? It's also part of the primary care team. Do we have a PharmD who's part of that team? Do we have an acupuncturist? So the patient can actually get one-stop shopping. They've got one store to go to. They go to the super Walmart. They know that they can get almost anything they want there. But if they need something specialized that super Walmart doesn't carry, they can go to a specialized store to get that. Next slide. So really the idea here is how do we start to deliver behavioral health services that are more of a population health focused? How can we provide less care, less intensive care to a greater number of people who by the sheer volume, you'll end up helping more people, even if you're less effective. And we don't really have time to go into what a population health approach is to healthcare, but if you Google that, you'll get some pretty good definitions of what that's like. So it's basically how can we have better access and deliver these kinds of services to the most people that we can in a way that can be effective. Next slide. So why teach integrated primary care? And I can see this. I'm trying to put myself into people that are, grad school professors, and your whole program or much of your program is designed around, let's just say generically, to produce people that are going to go do specialty work. Certainly, you have different specialties people can go into, or different tracks people can go into. But why would I want to bother, I hear about integrated care, APA talks about integrated care, but I'm having trouble just sort of meeting my goals here. And I think there's a couple of reasons. One is that by being able to introduce integrated care principles to graduate level and or clinical kinds of training, it allows those people to have more flexibility about what they choose to do. Some of them may not have any interest in going into primary care at all right now. That may change down the road. And what we do know is if you take somebody who's just trained to deliver specialty behavioral health services and you drop them in a primary care clinic and they haven't been trained to do that, they will quickly fail. I've seen it over and over and over again in multiple systems. So the other thing that I think was sort of surprising to me when I was at faculty on an APA internship, I was in charge of the primary care, integrated primary care rotation, and it was mandatory for our psychology interns to go through. And it was a month-long clinical experience where they observed me for a week doing this. We discussed all the patients. I observed them for a week doing all the patients. Then they saw all my patients with me next door. Then I followed back up again with them on that. So they had to learn. I trained them to a very specific set of core competencies. And the consistent feedback that we got was even for people that didn't really want to go to primary care training, they found it beneficial and it made them more efficient and more effective in their especially outpatient behavioral health work. So in 60-minute appointments, they felt like they were better able to assess what the problem was, come up with a shared decision about what are the goals for treatment, write that treatment plan out with specific things that patient could start doing that day. And because I trained the interns to write their note as they're in the appointment with the patient. When that patient walked out of the specialty mental health clinic, their specialty mental health note was 80 to 85% finished. And that patient walked out that day with an evidence-based informed treatment plan that they could start doing then. So they said it gave them a greater breadth and depth of skill that they could do more efficiently and more effectively. That's something we hadn't really thought of, but we were really pleased to find that because most of the providers, most of the interns we were training were initially going to go to specialty outpatient mental health. And now we knew that they could really crush it when they went out there. So next slide. So when we think about kind of where people get behavioral health, mental health services or care, it really kind of falls into a stepped care approach, right? A lot of people who are struggling will read a self-help book. They'll talk to a spouse, a clergy member, a friend. Some people nowadays, it's a lot easier to go online. You know, you can have AI-based or web-based things. There are a range of products that are available to folks at no or minimal cost. And then sort of like if we took this into kind of a medical problem, let's say somebody had a cough, right? And they're going to kind of treat their cough at home and their cough's getting a little worse. So they go ahead and they do some online stuff and they get an idea about what they might do. And so they do some more stuff, but their cough's getting worse. It's not getting any better. Well, their next step is to go to primary care, right? Because they've tried to address it on their own. And I think that similar trajectory can happen with people that have a behavioral health concern or a biopsychosocially influenced concern or problem. You know, they go to primary care, and hopefully most of those people that go to primary care are able to assess and address and resolve that problem, that cough, with the primary care provider, right? But what happens if it doesn't get resolved? Well, most of it can get resolved at primary care, but then there may be a small number of people that go on and they're going to go see a specialist. They're going to go see some other specialist that the primary care provider wants. Not unlike somebody who was being helped for behavioral health or a biopsychosocially influenced problem in primary care, if they don't seem to be functionally improving or symptom improving, well, maybe they do need specialty services. It's sort of like also the person that comes to primary care for a headache that doesn't get resolved. Well, now let's go see a neurologist, right? Some people absolutely do and need specialty behavioral health services. We want to make sure that we give people the right care at the right time for the level of problem they have. So we don't want necessarily people with adjustment disorders going to see specialty behavioral health because we know we can address those. We know we can address, and there's a growing mound of research to support this. We know that we can help assess, treat, intervene, and improve health function and quality of life for a range of behavioral health presentations and biopsychosocially influenced problems in primary care. If they're not getting better, let's get them to specialty behavioral health. And then for a tiny number of people, they need inpatient care, right? So we think about this as behavioral health on a stepped care. The right treatment at the right time for the right person, given what their current situation is. Jeff, next slide. So two of the primary models of integrated care delivery are a care management model, also known as a collaborative care model, and a primary care behavioral health model of service delivery. And then there are some clinics or systems that will blend those two models together. So let's take a little deeper dive of what these are. So care management model or collaborative care model is really a clinical care pathway. It's set up so that people are screened for a particular problem. The most common one and the one that was the earliest studied was for depression. People are screened for depression in primary care. If they pop positive on the PHQ-2, they get a PHQ-9. If they score in a certain range there, the primary care provider talks about bringing in a care manager to assist them with treatment. The care manager is typically going to be a nurse, but it could be a social worker, or it could be a master's level person, it could be a doctoral level person. They're delivering a very prescribed assessment at each follow-up. How are you doing? They have very specific modules or strategies that they can do. If they have particular challenging patients or they want particular medication recommendations, the primary care provider and care manager can bring in a psychiatrist. The psychiatrist is also part, a consulting psychiatrist is part of this model. And then when it's available, and this tends to be more in those blended models, they can also bring in a psychologist if they wanted to add additional skills in on other problems. Now, care management model is also being expanded for other things like anxiety, post-traumatic stress disorder. It's really a well-defined clinical care pathway where everybody knows what their role is, what the other people on the team, what their role is, and what the outcome is that they're looking for. Next slide. So when I hear people say, well, we're doing integrated care or we're doing collaborative care, I like to ask them, well, specifically tell me what you mean, because there is a real continuum of what that looks like. And Jeff, I think this is the slide that we've got movement on, right? Go ahead and hit the next one. So we've got coordinated care, which is, okay, your primary care folks are talking with mental health providers who are maybe not in the building. They could be in the building, or somewhere in the building, probably not in the clinic. And that can be helpful, but it's still, it's trying to like spray a fire hose through the opening of a Coke bottle. You're not going to get much flow that way. Patients end up no showing or canceling their appointments. Go ahead, next, Jeff. Co-located care is where you have a behavioral health provider who is in the primary care clinic. Now, that doesn't mean they're doing good integrated care. Co-located care only means you have a behavioral health provider in the primary care clinic. It doesn't mean that they're necessarily having a shared medical record. It doesn't necessarily mean they're not doing just 60-minute appointments. And while this makes it easier for a patient to get what's typically happening is specialty care, these specialists quickly fill up, there becomes a backlog, there's a long wait list, and then they start to become irrelevant to the primary care team because they're just not able to help their patients. So when people talk to me about doing co-located care, my question is the return on investment really worth it? I'd rather see you do this and explain to them their options because I think you're going to get this kind of return on investment if that's your goal. Next. So on the far end of this continuum is primary care behavioral health, our primary care behavioral health model of service delivery. Okay, Jeff, go to the next slide. We'll talk about what a PCBH model of service delivery is. So primary care behavioral health model, or PCBH model of service delivery, is where you have a behavioral health consultant. That could be a doctoral level person. It could be a master's level person. It could at this point now be an LPC, because there's some ways for that to get reimbursed that varies a little bit. But you are there to help the primary care provider and the rest of the team improve the services that they can deliver for behavioral health, mental health, unhealthy substance use, and biopsychosocially influenced problems like chronic pain, diabetes, asthma. Go to the next slide. We'll talk a little bit, get a little bit more into the details of what this model looks like. And so Jeff Ryder and Dobmeyer and I, at one point, there were a lot of different ways a PCBH model of service delivery was being defined. So we went ahead and in this article went through a process and actually specifically defined what a PCBH model of service delivery is. This is some of the highlights. If you go to that article, it goes into great detail. We'll give you an acronym here in a second. But really what a PCBH model is it's a team-based approach to primary care, where it's not just the primary care provider's job to help the patient, but it's the entire team's job to help the patient. So that behavioral health consultant or provider is there to work with the primary care provider, the nurses, anybody else that's on the team. And the goal is to help the entire team manage the full range of behavioral health concerns or biopsychosocially influenced conditions that people are bringing into the clinic, and to improve their ability to manage those particular problems. Even if that BHC doesn't have to be in the clinic that day, or somebody's moved on and quit that job. I mean, I knew when I was first started doing this, I think this was in like 2001. I knew I was doing my job well as a BHC. I mean, anybody who's worked in a primary care clinic or have been to primary care clinics, the ones I've been into, the walls can be really thin. And so when I heard the family physician that was in the exam room next to me saying to their patient exactly the same things I have discussed and treatment plan recommendations that I've recommended, and saying, here's what I think is going on. This is what I want to see happen. I want to bring Dr. Hunter in to help us get a plan and monitor that and get it going on. I knew I was doing my job in terms of helping that team learn how to improve or enhance their skills, but not doing it in a way that provided an extra burden on them. The goal is really to help provide services for the entire population of that, whoever's going to that clinic. So it's that population health perspective. You're a generalist. You see everybody, everything. There's no patient you can't see. Doesn't mean you can necessarily do anything with them, but you see all patients, and you see a lot of them. Go to the next slide, Jeff.
Great. And Chris, just so you know,
Yes, sir.
there's a question in the chat about billing codes. So as you're describing things, I don't know if you want to just comment on billing.
Yeah, what I'll say about billing codes is that is an ever-shifting landscape. And if you're interested in billing codes for integrated behavioral health, there are very specific ones for the collaborative care or coordinated care model. There are ones that may or may not be accepted depending on what state you are and who's funding those. I would encourage you to Google that, or go to other websites. If you go to the American Psychological Association website, Psychiatry Association website, the Collaborative Family Healthcare Association website, there are discussions and products that will tell you more about that, but that changes frequently. So I wouldn't even begin to make comments on that. That's not my area of expertise, but there's a lot of people out there that have been doing this, and the information is out there. So to try to make this really long primary care behavioral health model of service delivery definition a little easier to remember, we came up, we put it in the GATHER acronym, which was first put out by Patty Robinson and Jeff Ryder. And so this helps you look at what a PCBH model of service delivery is. Like we talked about, You want to be able to see all patients, all ages with whatever they're coming in with. In a perfect world, you want to see them the same day. We call that a warm handoff. If you see them on the same day, it eliminates a cancellation and a no-show. And you give a patient one-stop shopping if they can stay and do that. You're part of the team. So if you don't have, so you're going to the clinic morning huddles, you should be in them. Clinic meetings, you should be in them. Clinic trainings, you should be doing them. I took it to the extent where I was working in an active duty clinic, and their clinic was having their PT tests. I was not active duty at this point. I went out and did their PT tests with them because that's part of what a team does. And I had the ability to do that. If they're having parties, you go to them. High productivity. And sometimes people say, oh my God, how could I see 10 to 14 patients a day? So that's part of what training providers to work in primary care teaches them how to do efficient and effective functional assessments, functional biopsychosocial assessments. What's driving the problem? What's making it worse? What's making it better? What are the functional impairments? What are the quality of life impairments? Based on the best evidence that we have, what can we possibly lay out in terms of treatment plans? What does the patient want to do? Get them going on that treatment plan and they're out the door. So if you have 10, 30-minute appointments a day, that's only 5 hours out of an 8-hour day. And when we train the provider to actually write the note, they're facing the patient, they're asking questions, they're filling out that medical record note as they're doing this. There's still additional administrative stuff to do, sure. But even if I'm just seeing 10 patients a day, that's still only 5 hours of clinical time out of an 8-hour day. I still have 3+ hours because nobody just does an 8-hour day. It's usually an 8.5 or a 9-hour day. I still have all that time to go talk to docs, give feedback, finish up notes, finish my coding. And like I talked about, part of the educator thing is as you're giving feedback to providers, telling them, we set up a plan for the patient to do this. This is what I expect. They start to learn from those conversations. And you can also do lunch and learns. You do a 5 or 10-minute thing about here are the main behavioral treatments for insomnia. When you send your patients to me, as you've probably already seen, generally here's what we're going to do. Here's the evidence behind that. And these things you can do as well if you wanted to. Here's some information. Here's some handouts that would allow you to do that. And you start to be seen as a routine member of the team. You're not this outsider that's a visitor. You're there as part of the team, and you start to become a really valued team member. And when you're out, the rest of the team doesn't like it. When you're on vacation, they want you back. There was one clinic that had a full-time behavioral health consultant. That behavioral health consultant job was eliminated, and the chief of that clinic converted one of their PA slots so they could have a full-time behavioral health consultant. That's how valuable that team player became to that team. Next slide. I was fortunate enough to be part of this task force with Susan McDaniel and one of the authors on this American Psychologist article where we laid out what are sort of the core competencies for people you're training for integrated primary care. And the article goes into much more detail. In chapter 2 of our books, we extensively go into core competencies in clinical practice and management skills. But we want people to be critical thinkers. We want them to know the science behind this for specialty, what's been evaluated in primary care, and how can you adapt things based on theory, based on critical thinking, based on the goals you're looking for. How do you interact with leadership, administration? How do you make sure you're talking the same language? When you go to another country and you're going to live there, it's to your benefit to learn to speak the language, right? You want to be accepted and be part of that team. How do you kind of coordinate or merge things like ethics? Well, I have these ethics, especially mental health. Primary care has this. Am I being unethical if I do this? the ethics problem comes up over and over again, and we've addressed it in our system for the last 25 years. And still, every once in a while, we run into somebody that doesn't truly understand what HIPAA involves. So, what is the culture of primary care? Well, the culture of primary care, at least the ones I've worked in, is you don't call the doctors Dr. So-and-so, at least not face to face. I'm going to call you Frank or Tim or Lisa. And when they call me Dr. Hunt, I say, please call me Chris. And so that's not something you know unless somebody trains you to do it. How do you build those relationships? I talked about that. How do you manage your time? How in the world, in a 30-minute appointment, can I get good, actionable information, summarize that to the patient, lay out things based on that functional assessment that makes sense based on what they want, get them to agree to choose one, and then start them on that program and have them walk out of there at a 27-minute mark so they can go out to the waiting room and I can bring up my next patient and I can go out to the waiting room and grab that person. You can do that. But it's helpful if you have somebody who's training you to do that and training you towards a set of observed competencies. So it's not just read a journal article. It's not just, we're going to look at this PowerPoint, we're going to take a test. I used to do this with my psychology interns. I'd say, I want you to read these book chapters, these journal articles, and we're going to have, during our supervision, we're going to have a discussion about them. And they come in clearly that and I'd ask them a question. And after one embarrassing session, they knew, hey, no kidding, this guy's going to ask me very specific questions and I need to know this information. And then once they had that information, I had a clinical core competency checklist. Here's what you're going to be evaluated on. Here are your behavioral benchmarks that I'm going to be looking at. So it's not just, can you say it? I'm going to observe you doing it. And people will say they can do it and say they know it. And that's very different than them being in a situation with either a standardized mock patient or real world patient where they're having to deal with patients showing up late, the medical record not coming up and you having to reboot your computer. That creates a whole different set of clinical learning experiences. But if you're in the clinic as a supervisor and you're there, you can always step in and model the appropriate behavior and rescue them so patient care isn't being compromised. And then we talked about the teaching and supervision. Next slide. So why we wrote this book. So I first started in the clinic in 2000. And before going into the clinic, this was brand new. The Air Force brought in Kirk Strassel to train us. They had just had a draft of kind of the manual for primary care behavioral health. The reason I wanted this book is because prior to this job, at this point, I had a very good librarian. I pulled, as far as I could tell, every journal article and every book chapter written on integrated care. And a lot of it was based on theory, best guesses, because there weren't a lot of people working in primary care. So I had that knowledge base. I think a strong knowledge base of what's good evidence-based informed care for your general mental health presentations, as well as boarded in health psych. I mean, I really loved working with people with all kinds of chronic diseases, so I had that base. But what I had to do is I had to figure out how do I break a 30-minute appointment into digestible pieces that I can do over and over again in an efficient way. So the reason I wrote this book, or that I asked people to come collaborate with me on this book, is because I wanted people that are starting to work in primary care to have an off-the-shelf book that they could pick that was rooted in science, based also or influenced on clinical experience. And when you look at, here's how you might say this, here are the questions and how you might ask this. That's how I would say it in the clinic, right? I wasn't making it up to just be good reading. That's how I would actually say it to a patient. And we structured the book so that it was written in certain sections. So, oh my God, I'm going to see somebody with diabetes today. I've never seen some diabetes. Let me turn to the diabetes chapter. Okay, here are patient handouts. Here are the assessment questions I can ask them. Here are the interventions. I wanted it to be a user-friendly way, an off-the-shelf book that anybody could pick up. And if you'll just do the things in the book, at the very least, you're on an evidence-based, evidence-informed way of how you can do this. And so, now, we're ending up in the third edition. I think the book has evolved. I mean, this was a book that was sort of my brainchild. I wanted to do it. I got rejections from different publishers. I'll share just a little secret. APA rejected this book proposal at first. And they said, well, we already have lots of books like this. And being who I am, I said, that's not true. I said, I would like to know why you rejected this. And I'd like to know why the reviewer said this, because this book prospectus isn't like any other book. I even know Mark Hort, who you say that book's like this one. It's nothing like this book. And so what I heard was evidently people that can make the call on this had some discussions at APA and said, oh, you know what? I think we missed this. I think we do need to publish this book. So that's my plug on, if people are rejecting you and telling you no, kind of be like a small child and say why. It can lead to good outcomes. Okay, Jeff, I think you're up.
Great. Thanks so much, Chris. So I hope, we hope, that for those of you on the call who maybe were less familiar with PCBH and really what we mean when we're talking about integrated primary care, that you have at least a starting place in terms of understanding that. And you can dive deeper into some of the resources that we shared. I did want to point out, as Chris was talking about the book here, one of the features of the book that we have is all of the handouts that we talk about in the book are available for download. And you can take those, you can edit it. Unfortunately, I think they're downloadable as PDFs, so it'll take a little bit of work to edit them. But we're hopeful that you would take them and adapt them for your environments, for your situation, so that it's really usable. I think when we wrote this book, we really had learners in mind, and we wanted folks to be able to essentially pick this up and be able to use it. Use the information that was presented in each of these chapters with the next patient that you saw who might be presenting with some of those conditions. And so I'm going to take just a little bit of time here to give you a quick overview of how I've used this book in teaching graduate students. You've heard a little bit already how Chris has been involved in training residents and interns, and we can talk a little bit more about that with the questions as we go forward. Just to give you a little bit of context, I teach in a graduate program where it's a graduate program in clinical psychology. Usually takes 4 to 5 years at the school and then a year of internship. I have taught this course as an elective. It has lasted anywhere from 8 to 16 weeks. So I adapt what I'm teaching based on how long it is. And right now, in its most recent iteration, it's being offered as a 2-credit, but it's been as a 3-credit course. Most of the students who are taking this are doing it after they've had foundational courses in psychology. So these are foundations in understanding what psychology is, what clinical psychology is. They've had foundations in conducting interviews, doing assessments. Most often they've had a class in CBT at least, and some have had a background in health psychology. And I really do think having these courses, while I don't make it always required as a prerequisite, I do think that having this background makes it a lot easier for students to be able to kind of learn how to adapt what they have learned in those classes and to be able to apply them within the context of primary care. So I'm going to go through and just give you kind of a, give you a sense of um, how I've organized the course, and then we can talk a little bit about how there might be some adaptations to this. So when we start out in the first class or so, um, I find that it's important to just sort of lay a foundation about sort of what is primary care, helping folks understand what that is. Some folks, again, may not have had direct experience with primary care kind of growing up. Many have, but on occasion we have some that have not. And certainly don't understand the different specialties within primary care, whether it's family medicine, internal medicine, pediatrics, or OBGYN care. And then we, just as we started out today's class, talk about, why we should do integrated care, providing that rationale. And then going over core concepts like a biopsychosocial model, what it means to deliver step care. And then we didn't talk about it here, but talking about what the patient-centered medical home is, and the quadruple aim, which are all drivers within primary care that really drive ultimately the ways in which care is provided. In the, and so, we sort of build on that foundation. And so we use kind of the first two chapters in our book to really kind of talk a little bit about what are some of the competencies. Chris alluded to the idea of ethics and how ethics can be different in primary care settings. And we also talk about specific cultural considerations, both the culture of primary care and how you adapt to that, but also how you might adapt to the types of care that you're providing or the ways in which you're assessing to the cultures of the individuals who are coming in. We go over, Chris alluded to sort of these core competencies for BHCs. And so this is really talking about sort of the competencies that are involved in the practice of the PCBH model. And so we go through and we have a document that kind of lays each of these out and talks about very specific behavioral anchors associated with ultimately what clinical practice looks like, practice management skills, what consultation skills look like, documentation. As you can imagine, moving from specialty behavioral health care to primary care has very different expectations for documentation. And so we do talk about that in those first few classes. And then we talk about things like administrative and knowledge skills and team performance. And Chris has highlighted, I think, just how important it is for individuals who are working to be integrated in primary care to become part of the team and how to integrate with that. So we cover that in the first few classes, but very early on, again, to kind of emphasize this idea of, kind of what is primary care. One of the things that I do is I have, in my case, a family physician come into the class. Usually they'll take the entire class to really kind of talk about primary care from their perspective, what it is that they're doing and seeing in their daily life, and really talk about the value of having a behavioral health provider within primary care and how they would hope to be able to use that person. And I can tell you, out of all the classes that I teach in the context of this course, this is one of the favorite classes of the students, really being able to hear and understand what primary care is and how they can contribute to it. One of the things that I do, I have a link here, because I work in a family medicine department, I do focus primarily on family medicine. And there's a really nice video here. It's intended for medical students who might be considering family medicine. but it does a really nice job of really describing the specialty of family medicine and some of the core values that exist within that specialty. So those first few classes are really foundational, really trying to give the perspective of, again, why this is important. But then we start moving in the course to really the practical skills of filling the role as a behavioral health consultant. And so we introduce this idea of the introductory script, which is a script that we have all behavioral health consultants say before they start an appointment, which really lays out what the purpose of the appointment is, how this appointment is likely going to be different from any specialty behavioral health care that they might have experienced before this. And so it sort of lays that out. Our students learn how to kind of confirm the purpose of that visit. And then our book is really organized around the idea of the 5 A's. And we talk about how you do a functional assessment using the 5 A's. And we don't have time in this lecture to really kind of talk about each of these aspects, but just very briefly, the 5 A's that we're talking about here are this idea of doing an assessment, and then based on that assessment, kind of developing some ideas for a personalized treatment plan, describing those possibilities of the treatment plan with the patient, getting the patient to agree to how they want to move forward, and then actually delivering those interventions to the patient. And then once the patient has received those interventions, whether it's after the first appointment or after you've seen them, 2 or 3 times, thinking about, how are you going to follow up? What is that patient going to do? And maybe you're talking about sort of the follow-up with you as a behavioral health consultant. Maybe it's following up with their primary care provider, or maybe it's following up with specialty care. And all of these things really drive into developing this personal action plan, where both you and the patient have a clear sense of what is going to be changed. But we also have sort of the goal when we develop this personal action plan that somebody who wasn't sitting in the room with you would be able to pick up what this plan is, and know how to help that patient kind of move forward. Because within primary care, one of the real benefits is that individuals are likely coming back to that place. And so it may not be the BHC that's helping that patient move forward with their plan, but it may be other providers, maybe it's nurses, or even admin staff that's helping them to move forward. We talk about, in chapter 4, we kind of lay out the kind of common intervention strategies that really almost regardless of what individuals are presenting with might be valuable interventions. So more often, the expectation is students have already been exposed to most of these. We do talk about how you might adapt that for a primary care setting. But we do talk about kind of what each of these are, making sure that students understand, these types of interventions. And then we move into really talking about how you apply that within different types of presenting problems. We don't necessarily take time and go into depth for all of these things, but I'll pick out, some that I think are particularly relevant. So in chapter 5, we talk about sort of depression, anxiety, PTSD, and insomnia. We might break that up into 1 or 2 classes talking about how to do interventions, assessments and interventions for that. We also take time to talk about health behaviors. This is spread out across a few chapters within the book. And so that might be tobacco, targeting weight, physical inactivity, substance use, and sexual problems. And then we also talk about kind of chronic disease. And again, we don't usually have time to talk about each of these, but we're likely going to talk about things like cardiovascular disease or pain disorders and how we might target those. And then we also talk about how we adapt this to special populations and other concerns like managing suicide, working with older adults, working with children, adolescents, and parenting or couple distress. Sometimes we will take some time to talk about shared medical appointments, which kind of goes beyond kind of today's lecture, but the idea is that you're sort of bringing individuals in together in almost as a class. They're getting their medical appointment while also getting education about how to make behavior changes. The class is set up so that I will usually have folks do either debate in class or write a brief paper about the pros and cons of integrated primary care versus specialty care, because I really want folks to hone in on what those differences are and to have a really clear understanding. And I want to make sure that they have a clear understanding about how the care is different in each of those settings. Really, the big part about this course is writing this 20 to 30 page paper. And essentially what I asked them to do is to write a book chapter like what we have in the book. So they format the paper based on that. So they're doing a brief review of the literature, but really kind of focusing on how they may take what we know in the literature and be able to apply it in primary care. I do require that they're taking on a topic that we haven't covered in the book or isn't really covered in other books that might be out there. And so so it's nice for them to, kind of take something that they're interested in beyond what's already been done and create essentially the book chapter. And for me, I think that really helps them to kind of hone in on ultimately, what we're trying to teach, which is how do you adapt what you do in specialty care for the primary care environment. I also have them record a role play of an initial assessment, so get to see them kind of doing the 5 A's for the assessment of the presenting problem that they had written about. And so they work with a classmate or someone else. And of course, want to make sure that they do that in less than 30 minutes. We incorporate in terms of pre-class assignments. I have readings beyond kind of book chapters, having them respond to reflections and questions. There's videos that I'll have them watch that kind of give them a sense of what this looks like, and may have them do some special assignments like memorizing that introductory script and then kind of testing them on that within the class. This is where I get some of my videos from. Division 38 has actually a very nice course that they've developed where they have some videos. Those videos don't always exactly fit into the PCBH model, but it gives students a sense of what this can look like. There's APA has a YouTube channel with some if you do a search for, it should say integrated primary care, you'll see some of the videos that they have there. And then Beachy and Bellman Consulting, they have a lot of great videos on there talking about integrated primary care. Kent Corso has a few videos, and then really encourage folks to also look at the Collaborative Family Healthcare Association, which has a lot of great resources related to integrated primary care. Our co-author, Ann Dobmeyer, has recorded a video you can get from the APA. It's about 100 minutes. It provides a really nice example of a PCBH interview, but then also shows what it's like to then consult with a physician based on what they've learned from that interview. In class, we'll talk about the reflections, talk about the chapters and the readings, review assessment questions, and we'll do some role plays in the class as well. And Chris has already talked a little bit about how we do this in clinical settings. And so here's some other resources, again, in terms of finding out about integrated primary care. And we'll leave a few minutes here for questions.
Thank you so much. If anyone has questions that they have not submitted to the Q&A panel, please do so now. Chris, you've done an excellent job just flying through those, answering them via text. Are there any that you would like to speak more on live?
Not in particular, if somebody has something else they want to discuss, or if I gave them an answer that was unsatisfactory, we would try to address that.
Yeah.
But yeah, doing this is complex. It involves a lot. I mean, the questions you're asking are questions that are common kinds of questions, and a lot of them are concerned with the business side of this aspect. And there's an absolute business side, and it depends on what system you're in, what building you're in. Are you in an FQHC? Are you in a clinic? Are you in a hospital? What state are you in? Who's the payer? It's complex.
Mhm.
It's gotten better than it was 25 years ago, but it's still not where I would hope it would be.
I would also like to say that I appreciated your anecdote about how you made this book happen. Um,
Unknown truths.
always ask why, always ask why. Even if it is APA, we are not untouchable. So, thank you so much for that. That was an amusing moment for me, so I appreciate it. Again, some great questions asked in Q&A. Thank you, Chris, for answering those. If anyone has any remaining questions, please let me know now. But just a couple like brief housekeeping things before we wrap it up. A recording of this will be available. It will be in your inbox in about 24 hours from now. And then if you're waiting for an attendance certificate, please just be patient with us. It's a manual process, so that does take us a week or so to get that done. But I want to thank all of our attendees for your great participation and questions, and a special thank you to Dr. Goody and Dr. Hunter for being here and sharing all of your expertise with us today. We really appreciate it.
So I think we have 3 minutes left, and I'm going to
Yeah.
try to answer some of these questions live. So the first
Okay.
one, what resources do you suggest for creating a PCBH form from scratch? Well, our book's a good place to go, and it depends on what kind of form you're talking about. Are you talking about patient education handouts? I encourage you to have those be 1 page, be bulleted pieces that you can interact with the patient on. And, you know, we created our own forms. You know, what's our need? What's our educational need? What's our training need? I had a behavioral prescription pad that was blank that I'd write out the treatment plan on, or that had pre-positioned text where I could circle or cross out common things, so it would take me less time to do that.
And Chris, I think it's just about PCBH, not necessarily a form, but just kind of in terms of like creating PCBH from scratch. Yeah.
So if that's correct, then I would say the biggest thing that you want to do is you need to get buy-off from primary care leadership that has the ability to make decisions and hold people accountable to those. If you don't have buy-off from that person, then you're just one personality in there trying to make things happen. Somebody who can say, our primary care clinic is going to do this. This is why I bought off on this. This is what I want people to do, and can hold them accountable for doing what the clinic has decided to do, I think is necessary if you're going to be successful in primary care behavioral health. Jeff and I did a presentation at Collaborative Family Healthcare Association 2 years ago on that. It's what I saw in the Department of Defense. Underusing BHCs in primary care. Typically, I find that that is because the primary care provider has not been fully informed about what this is. Nobody spent the time doing that with them. So part of that is going around to each one of those primary care providers in either 5 minutes personally when it's time, when they have time, or doing a 10-minute, lunch and learn presentation, giving them a handout on here's the things that we can do, and getting the nurses and medical assistants that same information, because they are going to help. They're seeing the patient, they're seeing what the patient is presenting with. They can say, hey, Dr. Smith, should we bring Dr. Hunter on? Oh, yeah, that's a great idea. I didn't even think about that. So that's one of the ways that you can do that. But that has been my experience. There's just a lack of understanding, especially if you get new physicians on board and they don't have any in processing with what is the behavioral health consultant. Nobody told me we had this. I didn't even know it. This is great. Well, I'm going to send all my depressed patients to them. Well, that's a good start. But what about all these other folks, right?
And as Chris knows, oftentimes we would send out like weekly reminders about, like we would do a weekly special about, here, we can help with hypertension, we can help with smoking, we can help with sleep. And so each week kind of sending them something new, to remind them and to keep us top of mind in terms of, when they're seeing a patient, how we might be able to be integrated with them.
Yeah, one example is I had gone to a specific family medicine doc, had given them my handout on what I could do. They had that handout pressed on their bulletin board in their administrative office, and they were there for 6 months. And I went around with mine was a monthly special on overweight and obesity. And she looks at me and she says, "You can help me with my patients who are overweight and obese?" It's a repeating message. It's not that she hadn't heard this before. It's not that the one pager that she looked at every day didn't have that on it. She was just so inundated with everything that just those weekly specials. Hey, if you're seeing people with overweight or obesity, I can help you with that. Happy to see them. Oh, fantastic. Then what you'll see is you do that, give that to them in the morning. In the afternoon, they see people that are overweight and obese, and all of a sudden you have 3 referrals from them. So it's that constant messaging piece that I think is important. Now we're at 1 minute over.
We are, but that's perfectly fine. Thank you for
Okay.
everyone who's stuck with us. The majority of people have, so appreciate you. And thank you again to our authors for being here today. We appreciate you. So
Thanks for
everyone have,
having us.
yeah, thank you. Any final parting words?
This can be a very rewarding area to go into to both practice and to teach about. And there are a lot of great resources. Our book is one of them. And certainly encourage folks. We had our emails up there. Feel either one of us would be happy to talk with you and keep this conversation going. And really appreciate everybody joining us today.
I'd echo that. This is hard. Doing this well is hard. Doing it well has also been one of, if not the most rewarding experiences of my life. To be able to train well over 100 providers to do this and create a bunch of, I know this is narcissistic, bunch of little mini-me's who I know are out there and are providing great care in primary care clinics that patients wouldn't otherwise get. I don't know if there's a better reward for that. And it's hard. I mean, slogging it out as a clinician is hard. Figuring out what are the financial pathways, getting leadership buy-off. I mean, that's why all of these core competencies are important. The cool thing is you don't have to do it by yourself. There's plenty of information, there's plenty of experts, there's plenty of associations where you don't have to reinvent the wheel.
Great. Thank you so much. Thank you to everyone for being with us today. And it sounds like we will be continuing some of these conversations offline. So love that.
All right.
All right. Everyone have a great day.
Thanks. Bye.